Hello, everybody. I welcome all of you to this very interesting webinar on one of the newer developments in collagen cross-linking. We are very, very fortunate to have one of the pioneers of cross-linking, Dr. Farhad Hafezi, and one of the leading panels of corneal surgeons from across India who are doing large numbers of cross-linking, who will be participating in this short 1-hour webinar. So we're going to be looking at some of the new technologies of doing cross-linking at the slit lamp. Dr. Farhad will share his experience of PAC cross-linking and also cross-linking in other indications with us. And we're looking forward to this interesting session. I welcome all the panelists today. Dr. Rohit Shetty, who will be leading the discussion, Dr. Vikas Mittal, and Dr. Prema Padmanabhan, who are my co-panelists for this particular session. Welcome all of you.
Thank you. So we have a short video to be played, and then we will go to the presentation. Raman, are we ready?
So unmute, please.
Yeah. Welcome to this webinar. Good evening, all. Welcome to this webinar on cross-linking at the slit lamp and a new possibility. We have with us, we're very fortunate to have with us today Professor Farhad Hafezi. He's the medical director of Hilza Institute, Switzerland, a pioneer of cross-linking. The first paper of cross-linking had his name as one of the co-authors, and from then he's done phenomenal work, both as a scientist and a clinician. And after many years of work, he's come out with this new device, which helps to look at cross-linking in your clinics. It's a slit lamp-based delivery system, both for keratoconus, and also initially it was looked for more for infectious diseases, infectious keratitis, especially bacterial keratitis. Professor Farhad, all yours. And then the attendees can send us questions. There's a chat box. I'm sure you can text us your questions. In case you have difficulties, I think my co-panelists, Dr. Prema ma'am, Dr. Rishi, and Dr. Vikas Mittal, I think we all know your WhatsApp numbers. You can just send in a text and we will be more than happy to ask the questions for you. Professor Farhad, all yours.
Thank you very much, Professor Shetty. I first would like to thank you all for moderating this Sunday session, Dr. Swaroop, Dr. Rohit, and Dr. Prema. And also I would like to thank Entot Pharmaceuticals for facilitating this webinar. So I will take over the screen sharing. Do you see one slide?
Yes, we can see the slide.
Perfect. So the main focus of this presentation is cross-linking at the slit lamp, and this is why I will focus this is why I will speak quite a bit about PAC cross-linking and cross-linking at the slit lamp, and just briefly touch into what is best known, which is cross-linking for keratoconus. These are my financial interests for this particular topic. And as you know very well, cross-linking for ectasia now is an established technique. We know.
Sir, I'm so happy that you are asking me for. Yeah.
I'm sorry?
Everybody, please mute your mics.
Oh, okay. You all know that cross-linking for keratoconus is an established technique, which is being performed globally, several hundreds of thousands procedures per year. And ever since the upcoming of PAC-CXL for ectasia, the number of transplantations in countries with a registry like the Netherlands or the UK have dropped drastically. So we screen early, we treat early, and prevent corneal transplantation. In performing cross-linking, most of us nowadays still perform epi-off cross-linking, and this is not because of a lack of vision that epi-on would be the better choice, but epi-on has been for a few years now a quest, because the settings to get successful and effective epi-on are not easy to achieve. And I speak from my own experience. For years, we have been trying to modulate the factors by pulsing the light. Once the role of oxygen was evident, we tried to pulse the light, we tried to increase the fluence, we tried to accelerate the treatment, and finding out factors that need to be modulated so that epi-on would be successful. In 2014, we discovered oxygen as a central element, but ever since, it was not easy to find a balance. As you may know, successful epi-on can be achieved with adding additional oxygen into the equation, so a boost of oxygen. That makes sense, but at the same time, it also makes the technology even more complex. You need yet another element, pure oxygen stream over the cornea to achieve that. This is why I'm very excited about what my friend Cosimo Mazzotta has done over the past years. He has taken everything that was known from our publications, from others, and has combined it in a really intelligent way. In other words, I think he has solved the epi-on puzzle for successful epi-on without additional oxygen, with just using the oxygen that is in the air around us, by doing iontophoresis to get enough riboflavin into the cornea, and by using pulsed light. On top of it, high fluence, and on top of that, a very gentle acceleration. By doing all this, he has convinced me that his way of moving on in epi-on is the way to go. And he has now just published his 3-year follow-up data. So this is not just a concept. He has 3-year follow-up data with a very deep demarcation line of almost 300 microns by using a pulsed high fluence protocol, iontophoresis mediated normal ambient air. And this is what we need for the future. We need a simplified technique, not a complicated technique. So this is something I'm excited about also then later on in combination with an easy application at the slit lamp. And just another word on another recent development. Thin corneas are in reach now. The first approach to treat thin corneas was our 2008 swelling of the cornea with hypoosmolaric riboflavin. And then Susan Jacob came up with an idea of putting a contact lens onto the eye. Cosimo Mazzotta had an idea of leaving epithelial islands. All these techniques modify thickness of the cornea, and each one of them has disadvantages. Our original swelling technique is quite unpredictable in the amount of swelling. Some corneas swell a lot, others don't swell very well. Susan Jacob's technique has a massively reduced efficacy in terms of biomechanical stiffness because it blocks the oxygen transport. We have published this reduced efficacy 4 years ago already, and Wollensak has just published another paper on it. And the epithelial island technique just leaves very stringent of haze versus no haze on the cornea. So it was time to rethink the whole thing, and we started doing this in 2015. Instead of modifying thickness or theoretically even modifying riboflavin concentration, we decided to modify UV fluence, and in order to keep it as simple and reproducible as possible. So over the years, we developed the sub 400 protocol, which means that you have individualized fluences for different thicknesses. And the thinnest we have treated so far is 215 microns with success, keratoglobus cases. So by adapting the fluence, now we created the algorithm 4 years ago and we published it in 2017, but we did not want to present a concept to the community and everybody starts to do their own experiments on it. No, we followed up with a validation study that has just been submitted, and we have 1.5, it's not 1 year data, we have 18 months of data follow up. So a clinical validation of our algorithm, and it's been submitted with a high success rate of almost 90%, which was surprising to me. I didn't expect such a high rate. So as soon as this study has been published, you will have a means, this will be public knowledge, a means to treat down to 210 with validated clinical data. So these are the two major things I see in keratoconus in keratoconus treatment in the next 1 or 2 years. Really successful epi-on without the need of expensive machinery, and a way to easily treat down to extremely thin corneas. Now, making the transition to PAC cross-linking. Quite soon in the equation, we realized, this was about 2006 or 7, that the biomechanical stiffening effect of cross-linking that we use for keratoconus treatment is just one of several effects that happen in each and every cross-linking procedure, whether it's for keratoconus or for infection. And this will play a big role for slit lamp cross-linking. So we do not only stiffen, which is effect number 1, we change the tissue's resistance to digestion, effect number 2, and effects number 3 and 4 just kill everything living on and within a cornea. Knowing this and having seen what the WHO has done in Zurich together with the Swiss Federal Institute of Technology, this famous solar disinfection technique, where you take water, add riboflavin and expose it to the sun, and then bad quality water becomes drinkable because you kill everything within this bottle. When we saw this back in 2004, we realized this is a concept that can be translated to the cornea because this is more or less cross-linking. It's riboflavin and UV light. So starting to look into infectious keratitis, we soon learned that we are speaking not about a relatively rare disease, but about one of the major causes for global visual impairment. Increasing antimicrobial resistance will be a major element in the next 10 to 20 years. PAC cross-linking kills irrespective of any antibiotic resistance, and PAC cross-linking also kills in mixed infections. Fungal efficacy is lower for now, but we have recent data that make us quite optimistic on how to massively increase fungal killing also. And the costs are a global issue, and most often not the costs of the medication, but rather our costs. The doctor-related costs, if we tell the patient we need to see you back 2 or 3 or 4 times, simply the patient cannot afford coming to see us again. In 2012, we defined the new term PAC-CXL simply to make a difference in publications and to more easily and readily find papers on cross-linking for infectious keratitis. It was Jes Mortensen who in 2012 published a very interesting study following our initial report, our initial pilot study from 2008. And in 2012, the first only cross-linking eyes were treated. As you can see here, this was a very promising outcome in bacterial keratitis. But again, PAC cross-linking kills both arms, fungus and bacteria, and kills irrespectively of the antibiotic resistance. Knowing this, we started a study in Egypt in 2010-11, and sorry for the 2014. This was, I think, published in 2014. I'm not sure anymore, but the study started in 11, and we used the Dresden protocol. But what we did is we were too enthusiastic and took it way too big into too big of ulcers. So you can see 7.5 millimeters. Some of these ulcers were impending perforation. So in hindsight, we should have chosen smaller ulcers to begin with, just to see what the technology can do. So one arm was antimicrobials, the other was antimicrobials plus Dresden protocol. In the upper right, you see 5.4 joule, and it didn't really make a difference. Again, I think we exaggerated going too big too quickly. Over the next years, our main aim was to increase efficacy of the method and accelerate it. And to our great satisfaction, acceleration, in contrast to PAC-CXL for keratoconus, acceleration works quite well. The whole PAC cross-linking protocol seems to be much more independent of oxygen than the biomechanical protocols. So we were able to accelerate by a factor 10. So instead of using 30 minutes, we used 3 minutes in the next study, but still the total fluence, that's in the upper right, was 5.4 joule. We did a feasibility study in predominantly bacterial and some mixed ulcers that was published 2 years ago. Based on the feasibility, we started a more proper prospective monocentric study with Boris Kneiser in Israel. And we went to small ulcers again. As you can see, 3.2 millimeters in the control group that only received antimicrobials. There were also mixed infections. So the Vigamox bottle is just a placeholder. It's not only bacterial. And the treatment group was antimicrobial plus accelerated cross-linking, but still at a normal fluence of 5.4 joule. And here, the study was published earlier this year. We are faster in time to healing. And this is a significant difference for the N examined here. So this translates into less follow-ups, less doctor's visit, increased likelihood to kill during one single visit. And this was quite exciting to us. At the same time, simultaneously, we ran the same study in Egypt with Mohamed Hosni, but larger ulcers. Oh, sorry, these are some of the images that come from the Boris Kneiser approach. And as I said, we did exactly the same thing in Egypt with bigger ulcers, as you can see, over 5 millimeters. And of course, they would take longer to heal, but again, significantly faster when you add cross-linking. So you reduce the time to healing. You most probably also have a smaller resulting scar because cross-linking does something no antibiotic or antimicrobial can do. It increases the tissue's resistance to the digestion caused by the infection, and it increased the time to healing. The ultimate way to prove the effect of PAC cross-linking would be a prospective randomized controlled trial. And this is what we have been doing for a number of years now, using initially 5.4 joule and then switching to 7.2 joule. So we increased the fluence, and we had 2 arms. Either the patient was randomly assigned to PAC cross-linking only or to medication only. And what we found was quite exciting. It took us quite some time collecting data from Xiao Chen in China, Rohit Shetty in India, Mohamed Hosni in Egypt, Boris Kneiser in Israel, and from us in Switzerland. And what we have found is very exciting too. As you can see, small ulcers, but only cross-linking against only microbials, according to the AAO guidelines. And towards the end of the study, most of the cases were treated with a high fluence protocol as you can see here. And the results are just as good as antimicrobials. So we had a similar non-significant difference success rate of around 90%, and the time to healing had a tendency to be longer, but it was not significant either. In other words, light and riboflavin were just as good as antibiotics. As a clinician, I'm not pledging to only use PAC cross-linking in the future and omit medication, but for the sake of this study, we needed to separate the effects. And this is great. This shows us that PAC cross-linking is on its right way, and using 7.2 joule is by far not the end. We've just published a cornea paper where we went back to the laboratory, showing that going from 7.2 to 10 joule and to 15 joule, you massively increase killing rates in bacteria and fungi, which means that future studies should go even higher in the fluence. So I'm actively supporting a number of PAC cross-linking trials that have just started, and I'm involved in the protocols, and we go to at least 10 joule, and this will help us greatly in improving efficacy. But all of this taken together leads us to our vision. The vision is that so far, everything we have done is reserved to the few percent of the global population that are lucky enough to have access to the technology. And usually the technology involves quite a sophisticated setup. At least you need a procedure room or an operating room. But if we want to get cross-linking and PAC cross-linking to the global population, then we need to make it readily accessible. And one instrument we all share as vision healthcare professionals is the SLIT lamp. So our dream was to move the entire technology to the SLIT lamp without sacrificing, without making it a basic machine that only has the most simple settings. No, we wanted to do everything that is up to date and modern, but bring it to the SLIT lamp. So the requirements were mobile, lightweight, can be used at the SLIT lamp, but also in an operating room, should have all the intensities used nowadays that are reasonable, should have continuous and pulsed light and be battery operated, and above all, also affordable. Why is this so important? If you look at the whole thing on a global level, let's take a country like the US, where probably most inhabitants are in reach of an operating room. Still, cross-linking at the SLIT lamp would make a lot of sense because you reduce costs. 20 minutes in a procedure room or in the consultation room are way less expensive than 20 minutes or 30 minutes in an operating room. And also, as a cataract surgeon, I would hate seeing infectious keratitis patients in my operating room. So I would like to separate anything that is infectious from my regular surgeries. I would care less about the keratoconus cases, but the infectious keratitis, definitely not in my OR. And you could also use one device for several locations. Now, if you take a country like India that has mega cities that are very well served at, but then also again remote areas where the steady access to an operating room is more difficult, then we all know treating as early as possible is mandatory, both in keratoconus and in infectious keratitis. And so we have to bring the technology to the remote area and serve them and increase the coverage, and in other words, democratizing the access to cross-linking. Now, as playing devil's advocate, if I were to say, if I'm a skepticist, I would say cross-linking at the SLIT lamp could be a problem because of two things: the time spent at the SLIT lamp and the risk of infection. Now, let's look at these two factors. Time spent at the SLIT lamp, well, we are down, even in epi-off, we are down to 10 minutes. And for PAC cross-linking, we are at 3 to 5.5 minutes. So as you will see in the video that I will show you in a minute, it seems to be no problem at all to spend this time at the SLIT lamp. And the second thing, risk of infection. Remember these 4 effects I showed you. So if you have a keratoconus patient, you do not only stiffen the cornea, you do all 4 things at the same time. The keratoconus cornea at the end of a cross-linking procedure is sterile. The mother that comes into your consultation room and tells you that her toddler scratched a cornea, this cornea is more infectious than a keratoconus cornea after CXL. So I don't see why a risk of infection should be a major issue in cross-linking. And if you have an infectious keratitis case, you're septic to begin with. There's no reason to bring this septic patient into an aseptic environment. So these two obstacles, I think, are no real obstacles. And let me show you how we got the idea of slit lamp cross-linking. Basically, my MD PhD student, Olivier Richaud, came to me back in 2011 and showed me the latest generation of LEDs that were so small, they would fit on the tip of a Goldman tonometer tip. And this is when we started playing with it, thinking, well, if the whole thing is so small, why don't we just take it to the slit lamp, mount it on a slit lamp, and then start irradiating? Well, fast moving forward, it took a number of years to get from the initial setup with the UVX1000 with the black cross-linking machine we developed in Zurich in 2004, over the later technology to all the efforts we needed to take to come up with the final product, which is the CI device. Now, the CI device, I believe, will once again change the way we cross-link in the future, because it will give us many more possibilities and it will reach much more people. It can be used, as I said, at the slit lamp with an easy adaptation to a number of slit lamp models, or in the lying position. The CI device will give you 5 to 12 millimeters in irradiation zone. It will give you all the intensities that you see on the screen now, pulsed and continuous light. It has a beam profile that delivers 20% more energy in the periphery, and most of all is battery operated. You can use a power bank and a USB-C cable to charge the machine on the go. The C-base, the cradle you see, is also made to charge the machine. Let me just briefly show you how this works. It has, the machine has 2 calibration circuits. So you plug this in, and then this is not only a charging base, but also the calibration, a UV output calibration device. To make, and this is something amazing for the surgeon. You can see your irradiation area. So you have unobstructed view through the slit lamp, or even when using it in the laying position. Open the diaphragm for the UV output measurement. And that's it. And then it starts the routine. And then you're ready to treat. Let me just show you a treatment. That's a 3-minute video. I'm not sure whether please let me know, actively let me know whether you hear the sound. Otherwise, I will make it louder.
We can't hear you.
And now?
No, it's not audible.
Okay, then we have the subtitles.
On the right of your video, you have a option to increase the volume. Yes, it's already high.
I don't hear, but you can see we have the subtitles.
Yes.
And I will talk through it. What we realized is a very comfortable chair for the patient. You see, I gave the patient my chair, and we are in an operating room, not because, and we are wearing masks, not because of the procedure, but because of COVID-19. So that's a little annoying. So we had to make this movie in the midst of the Corona crisis. But as you can see here, this is my procedure room. This is not an operating room. We disinfect the area, and for a long time we were looking for a very effective and easy way to remove the epithelium as long as we still do epi-off and for keratoconus. And I'll show you a very easy way. The speculum is included with every riboflavin vial and is lightweight, so it doesn't pull the lid down in the upright position. This was my second cross-linking at the slit lamp here, so it takes a little bit of time. Again, the patient should be comfortable. And now the abrasio is very, very easy. This is a sterile cotton swab that was soaked in 40% ethanol, like a LASIK procedure, but in the upright position. So we don't have a well of ethanol, we just have a soaked cotton bud. And now you tap for 70 seconds. It took us quite a while to figure this one out because I wanted a technique that doesn't use any scalpel or hockey knife, because we will deal with more inexperienced surgeons in the future. And look how easy this is. And it works very, very well. The only thing you have to remember, produce fresh 40% ethanol or keep the bottle closed and only open it for a few seconds. Ethanol will immediately evaporate, and then this doesn't work properly. But here, and then rinsing at the slit lamp, this works like a charm. Now in the next step, we take the patient to a reclining chair. I will maybe briefly move the video forward a little bit. And here we check thickness with an ultrasound pachymeter, just to get an idea where we stand. And I recommend this since years now in every cross-linking procedure. Also in the lying position, you need to know where you're standing. This is the riboflavin we developed. And it's a riboflavin that was developed with Eberhard Spörl. And for now, you can use it for all epi-off and epi-on applications. Now you see here the white cap that was mounted on the CI device, and we scanned the label to allow for treatment. And getting into the correct working distance is easy. You simply focus on the apex of the cornea. I rinse off the excess of riboflavin, and then during irradiation, no need to add additional riboflavin. And what you see here is something that I learned to like very rapidly. It's the red fixation target on the other eye. It makes it very easy to keep steady fixation. You do not need an eye tracker in this technology. An eye tracker would only be necessary in customized cross-linking, but this machine does not offer customized cross-linking, but everything else that exists for modern cross-linking. And here, this fixation is extremely steady. We choose a 10-minute protocol for epi-off, and as you can see here, the patient doesn't move. It's quite amazing. And we also did cross-linking for almost 20 minutes for another study with the different fluents, and there was absolutely no issue for the patient. So it's beautiful to see that. Let me show you here. Yeah, that the patient doesn't move at all. And oh, sorry, now I skipped this. And after irradiation, we take the patient back to the reclining chair, measure pachymetry at the end of the procedure, place a bandage lens, and that's it. So this was the very first cross-linking procedure we performed. For the ease of the surgeon, we will implement a total of 10 protocols. Let me show you that are preset. Let me show you some of them. This is the Dresden protocol. I would not use the Dresden protocol in the sitting position, but if you want to use the machine in the laying position, for example, in a child or an adolescent, a young teenager that is not calm enough for the sitting position, then use the Dresden. Then you have accelerated cross-linking protocols, the 10 minutes, the 5 minutes. This is protocol number 4 is a PAC cross-linking protocol. This one here is the iontophoresis-assisted epi-on Mazzotta protocol. Here is another epi-on protocol, and the sub 400 protocol will also be implemented. So once you know the thickness of your cornea after riboflavin installation, you can enter the thickness, and the machine will calculate the fluence necessary. This is the CI procedure pack, and for now, the device is the only one that allows you label use of all indications of cross-linking. This is not off-label use for infectious keratitis anymore. Infectious keratitis was CE marked for this application. So you have a speculum, the riboflavin, and the consumable cap that protects from cross-contamination. As I said, it's CE marked. One very simple thing, we were asked repeatedly whether riboflavin would move down in the sitting position due to gravity. It does not. We already published this 3 years ago. And another thing is you do not need to reapply riboflavin during the cross-linking procedure. We also tested this and will publish this now just as a letter, because whether or not you reapply it doesn't change anything in the biomechanical outcome and in the killing outcome, simply because the saturation stays there long enough. So this was in a nutshell the half-hour overview about why I strongly believe that cross-linking at the slit lamp will help democratizing the access and making our lives easier in treating early, both for keratoconus and infectious keratitis. I would like to thank my collaborators. This is our ELSA, but also the University of Zurich Cell Biology Lab team. We are very proud to be able to do basic research published in Nature Medicine and Nature Genetics up to phase 3 trials in clinics, although we have a very small team. And for now, it seems as if our experts meeting 2020 will still happen physically in Zurich, according to the Swiss regulations. And I hope that some of you can join me and Dr. Shetty, who is also in the scientific committee for our December meeting. Thank you very much for your attention.
Thank you, Dr. Farad. I think that was a wonderful talk. And we have a few questions from the audience. Can I pose them to you?
Yes, with pleasure.
So there is one question from Dr. Meena, who's asked us, till we get the sub 400 protocol, what in your opinion should be the lower limit of pachymetry to which we can use cross-linking with, say, a hypoosmolar riboflavin?
Well, the hypoosmolaric per se works relatively well down to roughly 320 microns of stroma before you start instilling. The problem is you cannot always swell to 400. We have submitted 3 months ago, so my guess is the paper will be hopefully accepted in the next 2 months, and we have a very solid follow-up of 1.5 years. So it's not only an algorithm, but it's a validated algorithm. My guess is we are July, August, September, end of September, beginning of October, it should be readily available.
Wonderful. I have another question. You're using a different riboflavin which doesn't have any dextran, am I right? Or HPMC? Yes. So yes. How much do you soak with this? Do you soak the usual 20 to 30 minutes, or can we soak lesser, because then it'll end up that your soaking time is going to be much more than the actually radiation time.
Treatment time, yes. For now, it's 20 minutes, but we have set up a series of experiments using the new Leica multiphoton microscope that just came out, and we will start in August. So one of the questions we will have is how much faster can we go? I think 15 or 10 minutes, even 10 minutes will be realistic. For now, we recommend 20 minutes of soaking, and indeed it doesn't carry either dextrane nor HPMC.
Wonderful presentation, like always, Farad.
Thank you, Rohit.
And if somebody decides to do a LASIK or a SMILE extra on this, because many times the machines don't have the cross-linking machine fitted, so they just want to come back to the OPD and do it. Do you think it is possible with this?
Yes, thank you for asking. As I said, the number of protocols is not the final number. We just added 30 milliwatts for 45 to 90 seconds to cover the extra protocols. And what I haven't shown here, I should have, is it's very easy to use this in the lying position. So you could use it immediately after your LASIK or PRK procedure. The website, imagine.com, now just since the day before yesterday has very short videos for every single step of both applications, slit lamp and laying position cross-linking. We call it the classic way now. And you will see there how you can easily use it after refractive laser surgery, absolutely.
Dr. Vikas, you have any questions?
Dr. Hafizi, that was really a very good innovation. I think it may make a huge difference the way we do cross-linkings. So I was just wondering, after removing the epithelium, you made the patient lie on a reclining chair for doing a pachymetry, right? So since we'll be doing it in OPD or in outpatient, so do you feel that maybe we can do a pentacam or without touching it? Because I understand that you feel that infection might not be an issue in your setup, but we see a lot of infections, and in our routine OP also we see a lot of infections. So doing it in a keratoconus patient which has a absolutely normal cornea, I'll still be a bit hesitant. Maybe we can have a separate room for that in OP, and instead of touching it with a pachymeter, maybe we can do a pentacam also. Do you feel so?
Yeah, I think we all know that the pentacam will have more trouble being reliable due to the nature of the camera taking the image in a slightly edematous cornea without epithelium. On the other hand, you are perfectly right. With my ultrasound tip, it's not easy either to find the thinnest point of the cornea. In the past, we have often taken patients to the pentacam or lately to the MS-39 to see what's happening intraoperatively. So I think the short answer is yes. If you have sophisticated infrastructure like you have in a developed environment, of course you can. On another note, I haven't seen infections in years now, many years, and we use the ultrasound pachymeter tip routinely, even after cross-linking briefly.
And the second question is, you used alcohol, that cotton tip dipped in the alcohol and then used it. See, when we use the alcohol, we are quite conscious about alcohol touching the limbal area and ensuring that it we flush off all the excess alcohol once we have touched it. So how do you achieve that on a slit lamp?
It was briefly visible, but the video probably was short. If you have the same small syringe with the irrigation cannula we all use during cataract surgery, then I just spray on the eye. It works quite well. And because of the nature of the sitting patient, the cotton swab is damped in alcohol. And the second I start touching, there might be a little bit running onto the inferior limbus, but you don't really touch all the other areas of the limbus with the alcohol. And it's ethanol, 40% ethanol for a few seconds, and we rinse quite a bit afterwards. So I think we should be fine.
And the patient is generally comfortable. Patient is comfortable next to it.
The patient is comfortable. We started using 70 and then 20, which 70 burnt too much, 20 was not efficient, and then we slowly worked our way up to the minimal concentration needed to have a reproducible way. And 40% does not burn. We use oxybuprocaine and 1 drop of tetracaine, follow it a minute before we start, and then the patient has absolutely no burning sensation.
Okay, so a couple of questions on your PAC-CXL, where you are using it for infective keratitis. You have shown us various protocols where you have used it as smaller ulcers and the larger ulcers also. So in all those studies, did you take into account the depth of the infiltrate? I'm asking so because we do see, deeper infiltrates, and those have generally a bad prognosis as compared to the superficial ones. And when you said you mentioned about the fungal, so we see more fungal than I think the other developed part of the world. So I was just wondering that did you consider a depth also in it? And the second question for the same is, you have used quite high energy as well, right? So in those corneas, how did you measure the thickness? So did you have a cutoff for the corneal thickness before you use your high energy CXL?
Thank you for the questions. The first question was related to whether I consider the thickness of the cornea. Well, in a beginning infiltrate and small ulcer, we all know that the focal thickness over the infiltrate or ulcer is not heavily melted away, so thickness shouldn't be too much of an issue. If you look into a very large ulcer, then just give me 1 second, please. I'm sorry. Sorry, there was too much noise in the background. I think it's all about being realistic about what you can achieve with a PAC cross-linking approach. In all instances, you will always increase the tissue's resistance to digestion, which is positive. In a small ulcer, at the same time, the killing will be so predominant that you most probably in very small ulcers don't need antibiotics or antimicrobials too much. The game changes if you go larger, and larger automatically means deeper. Now, if I ask you as a cornea specialist, what do you expect from a 5 millimeter ulcer in an outcome? You will probably say, well, I will be happy to have a quiescent scar in the end, so I can take approaches to improve vision half a year or 1 year later once the cornea has calmed down. So you and we would be fine having a quiescent scar. In this case, thickness plays less of a role. Even if I were to focally damage the endothelium with my irradiation, I still would end up in a scar. In either instance, I just increase my likelihood of getting to a scar. On the other hand, latest results published in IOVS early this year from Theo Seiler's group have shown that the damage threshold level, even in a transparent cornea, is much, much higher than we had thought 15 or 20 years ago. The whole Dresden protocol 5.4 joule were based on an assumption that more irradiation would harm the endothelium. We now know that the threshold level probably is higher than 15 joule. And this is a reason why customized cross-linking can use 10 and even 15 joule without harming a transparent keratoconus cornea. Now, in an infectious keratitis, you don't have a transparent cornea. The light is scattered in all directions due to the edema and the microorganisms in the cornea. So there, the absorption is into deeper layers is even hindered more. So this is why we strongly believe that 10 and even more joule will have a beneficial effect and not have a negative effect on the endothelium if we go up.
I have a question.
So I think my co-panelists Rishi, Rohit, Dr. Prema, they'll also agree that we do see a lot of deeper infiltrates. So my perception is maybe in these smaller ulcer, can this be a confounder also? Because they generally do well, right? So it is deeper infiltrates that we have trouble with. So Rishi, Rohit, Dr. Prema, what do you feel about in our context this particular as far as PAC-CXL is concerned?
If I can answer this quickly, before this whole trial started, and that point of time, we did not. It was not named as PAC-CXL. I think our paper and Farad's paper came out. We published in BGO, and that paper, his paper, got in ophthalmology, and we looked at the series of our patients. But that time, the machine was the same, 30 minutes. Protocol and all that. And there is one paragraph we answer exactly what you said. The superficial ulcers, bacterial one, did much better. And that is what I think the countries like Europe and other places would see. And when we went deeper, I think it would induce more reaction. we had few patients with hypopion and all that. And in that study, what I was part of with Farad, it was very well controlled. We did not take in things which were very deeper eyes. So I think from our experience, published work, I think I mean, deeper you go, your reactions is completely different. And I remember the word Jarish. I think both you and Rishi would correct me if my pronunciation. Jarisexemia, right? Reaction where the bacterial endotoxin releases, and we had, when we go deeper, we saw more of these reactions. So I think it works wonderfully well in bacterial ones, which are very superficial in those studies. But we have never tried. I mean, we always looked at the 30 minutes one. I think now with the cross linking in the slit lamp, I think it's a completely different probabilities. I think I mean, this is what we found and what we published.
I have a feeling that just because he's suggesting increasing the fluence, you will have a deeper penetration, just like reducing the fluence has a superficial effect in sub 400. We are manipulating that. And that might be useful in some bad ulcers as a last resort before you think of keratoplasty. And in such cases, anyway, you're not too worried about the endothelium, You want to resolve the infection. And if you can salvage the endothelium, well and good. So it will be okay to use a higher fluence. And if that's going to be able to kind of at least avoid a few keratoplasties, it might be worth a try.
And
yeah.
And most important thing is the results work very well, because what Dr. Farad is using, the riboflavin concentration, the composition is completely different from what we are using. And if we are using with dextran, we're using with SPMCs and all that, everything has a huge, it's going to create more confusion, because it's going to hydrate and it's going to, and if we are going to do this in our practice, I think we have to follow what Dr. Farad has said. Use the same concentration, use the same riboflavin. I don't think we can use different riboflavin concentration with composition and expect it to work. Am I right, Farad, about this?
I fully agree, Rohit. And may I just briefly share my screen one more time? Is that okay? Because just let me show you this one graph here. 527, sorry, 320 here. Now you should see it. We just published this earlier this year in Cornea. And if you look at this graph, do you see my pointer?
Yeah.
Do you see my pointer? Yeah.
Yes.
See, this here, this is 5.4 joule, and this is the killing rate that we had in a very in a well-defined bacterial strain. This is 10 joule, and the killing rate makes a huge jump, and at 15 joule is at 99.9% for this very particular strain. So as you can see, there is a means to massively increase efficacy in the future. Just 10 days ago, I had contact with the University of Sao Paulo, and Brazil is is a little conservative against PAC cross-linking, which I totally respect, but they had a nasty case of therapy-resistant infectious keratitis where everything had been tried. It was a mixed infection. And they asked me, trying cross-linking as a last measure, which settings they should use. And we went for 10 joule, and the next day had a massive improvement. And it indeed, as Dr. Rohit has mentioned, it indeed has elicited a larger inflammatory response, this Jarisch-Herxheimer response, because of cytokines released, but also because you kill a lot of microorganisms at the same time. So you indeed create even a hypopion. Just don't be surprised to see a lot of dead microorganisms in your anterior chamber and inflammatory cells if you kill a lot at once. But they worked in this area of efficacy, and they were so convinced that Sao Paulo will now start their own prospective PAC cross-linking trial with 10 joule. So also here, the blue bars and the green bars just show you the difference in efficacy in bacterial killing between 5.4 and 7.2 joule. If you go to 10, you're much higher. And we are working on the same thing for fungi now.
I have a question, Dr. Hafezi. You showed us that your endpoint for the PAC cross-linking was time to resolution, but were there any treatment failures which didn't respond to treatment and you had to do some other modality of treatment like a keratoplasty? And how did the treatment failures compare in the two groups?
In the prospective trial, we had two treatment failures and one perforation. The perforation was, oh no, sorry, this was the Egyptian study. Sorry, I'm mixing up. In the multi-center trial, we had two treatment failures, but failure in PAC cross-linking was defined as patient did not get immediately better within the first 48 hours after cross-linking only, and patient needed medication, additional medication. That's a treatment failure. So 2 out of these 23 patients needed additional medication, but they all healed. These were, as Dr. Shetty has also mentioned, these were rather small ulcers. I'm still very optimistic for mid-size ulcers based on the up to 5 millimeters based on the Egyptian study we have done. And even in large ulcers, I would still do cross-linking because you increase the resistance to MMP9 and other collagenases. You just have to be very realistic. You will not change the game. You will not see a miracle happening if you use it in a 7 millimeter ulcer. You will have more inflammation the next day. You will make the cornea a little more solid, but the cornea's fate probably will largely depend on the other medication.
We have a few questions.
I think Dr. Prema,
Dr. Prema has a question.
Yeah, if you don't mind. Our own experience, Vikas, to answer your question with fungal ulcers, we chose only ulcers which were superficial in their depth of involvement, and in those eyes it did do well. We used the normal Dresden protocol. But my question to Dr. Hafezi is, you talked about two kinds of protocols. One was the slow and low, and the other was slow and high. Of course, your preference seems to be for the slow and high. My concern was about what it does. Of course, it's more effective in killing the bugs. It's safe as far as the endothelium is concerned. But what would be your thoughts about what it does to the keratocytes? Because if it completely destroys keratocytes in such a large area, we need those keratocytes, particularly in infectious keratitis, for the healing to occur.
Yeah, absolutely. You will kill the keratocytes, but you kill the keratocytes to an extent that is similar to what we do in keratoconus treatment. I do not know to what extent the killing of the keratocytes will positively or negatively influence the healing reaction. But as you stressed out, and I saw your paper, it came out about 2 weeks ago, right, on fungal keratitis, and congratulations, this is nicely done. We have discussed this briefly yesterday. I would still now try to go to higher fluences and see the effect. So do something similar you have done in your last study, but move the fluence up to 10 joule. And certainly you're changing the physiology of the cornea in terms of keratocytes, but they should repopulate. And so far the beneficial effect, I think, is prevailing there. Any negative effect you might have by killing keratocytes.
There is a question from Dr. Hijab Mehta, Bombay. What about the corneal drying during the procedure, since we are not putting any riboflavin drops? Because of the exposed stroma, is it going to become more compact and thinner because of drying?
Okay. Well, two things. We apply BSS during irrigation every 3 to 4 minutes with the irrigation cannula. So in the sitting position, that works well. About a year ago, we came up with an idea that maybe after having spoken to Eberhard Spörl, that maybe reapplying riboflavin is counterproductive in any cross-linking reaction, because the cross-linking reaction means photons hitting riboflavin molecules, riboflavin being bleached, doing its effect, and then not being available anymore. So with every second of irradiation, you go deeper and deeper. Now reapplying riboflavin on the surface and the superficial cornea would reset the whole process to superficial layers, which is counterproductive. This is a theoretical consideration. I asked Hormos, one of our students in the lab, to simply do Dresden protocol cross-linking, and we have submitted this now. On one hand, do a full Dresden protocol without reapplying riboflavin, and do one with dropping the typical 2 to 3 minutes. And theoretically, the one where you redrop should have less biomechanical effect. No, it doesn't. It is the same biomechanical effect. So the theoretical consideration probably does not translate into any clinical disadvantage. But it also means that you do not have to. You do not have to redrop riboflavin at all during the Dresden protocol. Even half an hour works without reapplying the drops. And drying out the cornea, well, just rinse it with BSS from time to time, and your cornea shouldn't dry out too much.
There is one more question from Pune, Dr. Sangeeta Wagh. How deep is the demarcation line in a 250 micron cornea for the sub 400 micron protocol?
The algorithm that Sabine Kling and I developed and published in 2017 tried to keep the demarcation line 70 microns before the endothelium in all cases. So in a 210, it should be at 140. And this is what we have seen. We have submitted now the first 2 keratoglobus cases treated with around 210 microns and a 2-year follow-up. And so far, these corneas are stable. And you see the demarcation line in this extremely thin cornea.
I have another question. In the PAC cross-linking, you know, the infiltrate can be, say, 5 millimeters of size. Would you extend the epithelial defect how many millimeters beyond the edges of the infiltrate, or do you use a standard size of an epithelial defect, say 7 or 8 millimeters? What do you do?
We use what Paolo Vinciguerra has suggested in his, he called it window absorption paper. So the epithelium is dead over the infiltrate/ulcer. And so all we do is take a sterile sponge, a dry sponge, and wipe away everything that we can over dead cells from the surface, and then use that window for the riboflavin to penetrate. Now the horizontal propagation speed is twice the vertical propagation speed. This has been published many years ago. Once you have saturated for 20 minutes, you have also saturated the cornea under the epithelium. And then we irradiate in a normal diameter. So if you want, so it is epi-off over the ulcer, and it is sort of an epi-on irradiation over the areas of the cornea that seem to have no infiltrate, but certainly also a certain microbial load that we cannot see with our eyes.
And it is best not to remove the lot of epithelium surrounding it, because that would answer Prema ma'am's question, because you need keratocytes from the other areas to repopulate. Basically, when we worked on confocal microscopy, we see that when one part of a keratocytes are dying or dead or apoptosis, the keratocytes from the surrounding area actually covers it up. So that is one of the things that probably answers your question. Even though you're killing the keratocytes vertically, the one around that area are healthier and they come in to the picture.
That's a good point, Dwight. Yeah.
Sorry. Why don't you reduce the area of treatment to only and restrict it to the area of the ulcer and its infiltrates to allow the remaining keratocytes to survive?
That's a very good point. And we simply don't have the numbers to do a comparative study. But once we have standardized approaches, this would be something worthwhile looking into. My consideration was that I probably only see the tip of the iceberg. If I look at the ulcer through the slit lamp, I see what is clearly visible to my eye, but everything else that spreads to all sides, I also want to treat. But whether or not a focal approach or a large approach is the better one, we would need a comparative study someday. Yeah.
Another extension of this is that if the ulcer, if the infection persists, especially in the fungal ulcers that we see, they are likely to be linger in the deeper part of the cornea. And if you had to do a re-scraping, it's less likely that you will be able to harvest the pathogens, because the superficial part would completely have been
Yeah.
sterilized by the.
If I were to do a fungal keratitis study, and as I said, we can't do one easily in Switzerland because we don't have the number of cases, but I would try to increase the fluence, and in the next step, I would try to cross-link more than once to see what happens if you do a fraction cross-linking a second time a few days after the initial cross-linking. Maybe it needs more than one approach to kill all the fungi.
I have a question, Parad. When you're this is something similar to what ma'am asked. You're doing the second cross-linking if it's for a deeper one. So if you are actually doing the first cross-linking to kill the bacteria, you're changing the stiffness of that area. And if it's really deeper, then the antibacterial what you're going to use, the penetration of the antibacterial to that zone will be much lesser. So I think this also needs to be kept in mind if we are treating very deep ulcers, and if it fails, then the effect of antibacterials or antifungals it probably will have an effect, because the penetration of the cornea is completely changed then, because we are going to make it more stiffer, unlike your regular corneas in an ulcer patients where it is easy for it to go through. So that is something which need to be kept in mind.
Unless Rohit, if we restrict the area of treatment,
Yeah.
the antibiotics could then, the horizontal percolation of the antibiotics, just like the horizontal percolation of the riboflavin, should work better.
But if you're having a larger zone, then there is
If you have a larger zone, I agree with you.
because the second question is, Farad, many years back, we had discussed that. I mean, in your slides, you are shown Vigamox or moxifloxacin. Many years back, you mentioned we had discussed about this, that moxifloxacin and riboflavin has the same fluence. So if you use moxifloxacin drop just before you're doing a cross-linking, the action, the moxifloxacin component also tries to compete with the riboflavin for the same fluence, because it also has the same 370 nanometer excites at that fluence. Am I right? So you think that before especially doing this PAC-CXL, using a different antibacterial which does not compete with the riboflavin would be a choice?
Yes and no, right. You're absolutely right. There are substances that might interfere. What we have found some years ago is that fluorescin is a major problem. If you stain the ulcer 2 hours before you do the PAC cross-linking, then indeed the fluorescein competes for the absorption of UV light at 365. But interestingly, the quinolones, although they also can absorb light around 350 nanometers in a peak, they didn't interfere too much. So luckily, doesn't seem to be too much of a clinical issue to have a cornea that was exposed to quinolones. Just simply do not stain the cornea with fluorescein prior to PAC cross-linking. That would be
and
problem.
also I think the riboflavin will ultimately wash off, so it's not that it's going to stay for long. So once that has washed off, so there is nothing to antagonize or interrupt with any other antibiotics. But I think that there's a deeper one, and fungal, it's really exciting thing. Maybe since we have already limited things in our hand, and having another modality, I think it would be exciting to see what comes up.
Absolutely. Just one more word to the drug penetration. If I remember well, the drug penetration comes from the Bern group in Switzerland, and they haven't tested, I think they have tested pilocarpine and showed that it is much harder for pilocarpine to enter the cornea. To my knowledge, nobody has tested this with antibiotics. Probably any substance has a harder time to get through the cornea, but it would be worthwhile testing.
Because, I mean, it's worthwhile testing what happens to a drug after you cross-link. Probably you can test it in the lab, because if you cross-link an eye, the penetration of the drug is not going to be the same as it was before cross-linking.
Yes. And
So I
this
think,
was shown for pilocarpine.
yeah, I think this would be a good experiment your lab can do. Cross-link and cornea and test the drug penetration versus a non-cross-linked eye.
Yeah, as I said, Beatrice Rui has published this 6 years ago on pilocarpine, but as you also say, antibiotics haven't been tested yet. Yeah, that would be interesting to know. Yeah.
The last question I have is, do you think that using other substances, other than riboflavin, like rose Bengal, or one of these things, using a different
Yeah.
fluid, would have a better efficacy in PAC-CXL compared to using the riboflavin?
Yeah, I visited Bascom Palmer a few months ago, and Irene Kocheva from Harvard was there, who started using rose Bengal, and then clinically the Bascom Palmer group, and they have very interesting results. So I think that was one of the reasons why we called the whole technology PAC cross-linking, which stands for photoactivated chromophore for keratitis and not photoactivated riboflavin for keratitis, because there might be indeed other chromophores that would be very interesting to look into. So the killing rate of rose Bengal for fungus is quite interesting, and the wavelength penetrates deeper into the tissue. So hopefully we will see a constant improvement on the technology, and who knows how we will perform PAC cross-linking in 5 years.
There is a question, how about limbal protection during slit lamp cross-linking?
Well, if I look
we already
at,
discussed.
okay, yeah, the diameter can be chosen so that you are in safe distance from the limbus, just like in any other cross-linking procedure.
And how do you make sure that they remain in focus? I think I'd asked you once before, but I think it would be of interest because, you know, in our setting, the patients don't keep their head against the band. They keep going back, especially the older patients. It's difficult to keep them steady for 10 minutes. You know, do you recommend putting some sort of a band?
We've performed now a dozen crosslinks because we only received the CE mark like 4 weeks ago in the midst of the Corona crisis. So we started crosslinking 2.5 weeks ago. So far, we didn't encounter problems, but we chose young to mid-aged adults. I luckily don't do crosslinking very often in a patient too old to be steady, and I wouldn't do it in a child, but everybody in between. With the fixation light, the comfortable armrest, so the patient is not in a weird position, we had absolutely no issues. And all you need to do as a surgeon, and you see the eye through the slit lamp, is to focus on the cornea. The machine has a curler optics, which is similar to a slit lamp and which forgives you 5 millimeters of misalignment. So if accidentally you focus on the iris even, which should be 3 millimeters, you still are at 95% of the normal output. So the range, the safety range is plus and minus 5 millimeters of disalignment, which is huge on a slit lamp.
I have a small suggestion. I have a small suggestion. Since you are doing only the installation of the drops on the reclining seat, why don't you give the riboflavin in an eye drop kind of a bottle rather than a syringe? And then patient can be just sitting and you can instill it like you instill eye drops in the waiting room. And you can then again take the patient back on the slit lamp. You could save a lot of time and make it more comfortable. And the eye would also be more comfortable because you will not have a speculum there.
That's theoretically that's absolutely true. We chose the syringe for a number of regulatory reasons, and we also prepare the iontophoresis applications. But you're right, even there we could have had a bottle. For now, we are using the syringe approach, but the glass is also chosen at a wavelength that blocks UV light because of riboflavin getting bleached in the container. So for now, I've never seen a plastic bottle for riboflavin, and my guess is it has to do with the regulatory and the material of the plastic and the riboflavin. But we are hosted by a pharmacological company who knows much more about these issues than I do.
Dr. Hafiz, I think this would be, maybe last question. So you said that you can use this in OR also, in operation room settings also, right?
Yes.
And you are making the person recline in the outpatient also. So I was just wondering, why not have a stand and use it just like the patient reclines in the outpatient itself? What is the added advantage of using this system on the slit lamp? You can always do the reclining thing in the outpatient and patient will be very comfortable.
Yeah.
10 minutes lying
Yes.
down is definitely easier than sitting up. So why do you want to put it on a slit lamp?
You are absolutely right from your point of view. So you have a setting that allows you the OR, the reclining chair. And this is why we made the device available in both lying and sitting positions. But please look at it on a global level. And we have just had a series of long discussions with the Himalaya Eye Hospital that tells us we have remote areas that are visited once a month, and we have one doctor covering 1.5 million people in the Himalaya. He has a slit lamp. That's all he has. So we needed to have a machine that on a global level can cover all approaches. And if you are more, if you are comfortable with the lying approach, nothing keeps you from using the machine in the classic way. But we needed to have a machine that can travel with you to the most remote areas and still provide the technology to those who didn't have access until now.
And because it's just not for the patient, for the humans, it can also for the four-legged creatures.
Yeah.
I mean, you can if you have a horse, cow, dog, of any. I think it's a boon for veterinary science. Also because you can now treat a lot of infectious things. It's very difficult when, especially to put drops for them. I think it's really a boon. So it's one of those rare products where both veterinary and this both can use the same technology, and I think
Agree. I agree. I agree that you can have this like handheld cross-linking machine. This is amazing. I was just wondering that do we really need to have an adapter and all those things, put it on the slit lamp? So from technical or scientific point of view, do we have an added advantage if I put it on the slit lamp versus I use it in the reclining? That's what I was thinking.
I remember seeing in one of the conferences a small device which you could directly put on the eye, which was delivering a UV, almost like a small cylinder. I don't know if Dr. Hafezi has...
I saw that too.
Yes.
I saw that too, but our idea was not just providing a simple device with one single fluence and then you place it and you don't even see what's happening.
Yes.
The device you see now can be used in the conventional way and in the modern way, delivering 3, 9, 15, 18, 30 milliwatts pulse and continuous light. In other words, every single validated most cross-linking protocol that there might be, including extra applications, can be used in one single machine. If you want a single device that doesn't need a slit lamp and that is just put on the eye, then yes, that would be an alternative. In Switzerland, after 15 applications, you would start spending more money than with the device that goes to the slit lamp, because it's a single-use machine on top of it. You do one cross-linking and you toss it. So yeah.
Kudos for developing such a fabulous device, and I hope
Thank
it
you
can
very
be
much.
affordable for our country.
That's the aim.
Much,
it should be available.
Yeah.
Thank you very much.
Thank you so much.
Any questions more from the panelists?
I think there is one question. Have you had any vasovagal attacks? And one more question. Any experience with viral or a mixed infections?
With viral infections, I would not go with it for now. If you have a clear suspicion of a viral keratitis, I wouldn't perform cross-linking. With mixed infections, yes, quite a few of the cases in the studies that were shown in the presentation were mixed, but I didn't understand the first question.
Vasovagal attacks, because sometimes on slit lamp, patients have a vasovagal attack and they start sweating and yes. Have you had any?
So far, knock on wood, I didn't see that yet. Yeah.
Rishi, he has done only dozen of them. So
I know.
You need to wait for that.
Okay.
Thank you.
Thank you, Dr. Farad.
Okay.
On behalf of
Thank you very much to the entire panel.
Dr. Vikas, Dr. Prema, Dr. Rishi, and Todd, I think it was a wonderful session. And along with you, I think we should thank your wife, Nikki Hafezi. I think she was very instrumental in bringing this up, because I've been following this for the last 10 years. And please wish her on behalf, she's an entrepreneur, and really you need somebody to take your ideas from your drawing room to a lot of us have ideas, but we get stuck with our patients and sometimes cannot move forward. I think you're lucky in that way that she takes care of your ideas and brings it to a business model. I think
it was absolutely. It was an incredible vision of perseverance and getting through this entire process. Because otherwise, as you say, if it was only me, it would have stayed a beautiful concept and idea, but it never would have become a product. Yeah. So absolutely, without my wife Nikki Hafezi, we wouldn't be here now.
And thank Todd and all the delegates who participated in this, and wish to see you again in December with hopefully more results, and all the best. We'll wait for this to come to India shortly.
Hopefully, yes. Thank you very much.
Thank you so much. Thank you, everyone. Thank you.
Thank you all. Bye-bye.